Good evening and welcome to the Roselle Centers for Healing webinar series. My name is Dr. Harlan Browning and I will be your presenter tonight covering common pain disorders of the wrist and hand. So without further ado, let's dive into the discussion. So in tonight's presentation, we're going to go through several different components, starting with definitions and statistics of carpal tunnel syndrome and other pain disorders of the hand and forearm. We're going to look at three models of injury. We can apply these models to certainly tonight's topic, but we can also apply it to any type of injury pattern in the body. We're going to look at your pain type. If you understand the type of pain you're experiencing, it's much easier to understand the problem that's causing it. We'll, of course, look at the layers of anatomy. If we have a blueprint to the arm, it gives us a better understanding of the underlying causes again. We're going to look at various nerve entrapments in the upper extremity. We're going to extend that basically from the neck all the way down to the fingers. We're going to talk about referred pain patterns that can mimic carpal tunnel syndrome or other pain disorders of the hand. And finally, we're going to talk about clinical assessments and conservative treatments. How do we fix these problems without not having to resort to surgery or taking chronic medication? Before we begin, let's just talk about what the definition is of carpal tunnel syndrome, because you need to know this when we look at all the other patterns of hand and forearm pain. Carpal tunnel syndrome, or CTS as we call it, occurs when the median nerve, that's a nerve that passes through the wrist, becomes either pressed or squeezed. When this happens, we get a distribution of pain or numbness and tingling into the thumb itself, the index finger, and the middle finger. So if we look here, here's the carpal tunnel, and this is the median nerve, and it's going to these fingers itself. So if the hand involvement involves the pinky, and I'm going to talk about this over and over again tonight, then you may have carpal tunnel syndrome, but you probably have something else as well. Statistically, carpal tunnel syndrome is the most common nerve compression disorder of the upper body. Roughly 3% of the general population will experience it during their lifetime, and 5 to 15% of an industrialized situation will experience it. So people that use their hands repetitively, maybe assembly line, construction, typing, things like that, will experience it. In the year 2000, 463,637 carpal tunnel release procedures were performed with a cost of approximately $1 billion. So certainly quite a few people had the procedure done, and the cost is pretty high. Nearly 2.8 million Americans report they suffer from repetitive stress injuries, including carpal tunnel syndrome. So some of the other disorders that we're going to talk about this evening that mimic carpal tunnel syndrome are repetitive injury situations. So we're going to look at those as well. According to the Bureau of Labor Statistics, upward of 60% of all workplace illnesses are repetitive stress injuries. So if you're doing a procedure over and over again, then you run a greater risk of fatiguing those tissues and developing these repetitive stress injuries. Between 10 to 25% of all carpal tunnel surgeries are considered unsuccessful. So this is an important component of tonight's topic. You want to make sure that you exhaust all conservative measures before you consider surgery. You cannot go back. Most revisions of surgeries are not as good as the original. So we want to make sure we get it right the first time. Most of the time when we injure ourselves, it involves one of these three models of injury. It certainly could be a combination of all of those, but I think if we look at them individually, it gives you a better understanding of how we damage our soft tissues, our bones, our joints, and so forth. The first one is a compressive type injury. That means a physical compaction of a joint. In other words, we jam the joint up, or we contuse soft tissue or bone. A good example would be we fall off a bike, we put our arm out to stop ourselves, we jam the wrist up, maybe we bruise the bottom of the hand, we possibly might even bruise the bone. So compression is certainly something that we see a lot in our office. The second one is shearing. That would be the physical distraction or separation of joint surfaces and connective tissue. A shearing injury would be the athlete that damages his ACL while he's running. The football player is going down the field. He plants his foot to cut. He turns. The foot doesn't move, and the leg rotates in a counterclockwise fashion, and the ligament becomes sheared and it stretches. And the last one, and I think probably the most important one for folks that are dealing with carpal tunnel and syndromes that are similar to it, is repetitive activation. We do a reoccurring muscle contraction beyond its physiological capacity, meaning that we use a muscle or a joint over and over again beyond its ability to handle that, and the tissues will literally fatigue, and as they fatigue, they'll fail and break down. And the breaking down will lead to things like inflammation and tendinitis, nerve entrapment, and ultimately, for some people, scar tissue formation. So as we talk about these different compartment syndromes and other types of overuse injuries, we're going to reflect back on these three models of injury. If you ever seen one of my presentations before, you know I almost always put this slide up because I think it's really essential to understand what your pain type is, because if you look at the type of pain you have, it becomes a little bit more straightforward to understand what's causing it and hopefully develop a therapy to fix it. So the first thing we ask ourselves is our pain acute versus chronic? Meaning acute, we've only had it for a short period of time, maybe days or weeks, or is it chronic? We've had it for long periods of time, several weeks, months, and for many people could be longer than that, years. So we need to differentiate between the time frame, how long have we had it? Is the pain local or global? Local meaning, is it isolated to just my wrist or my hand, or is it global? My whole body hurts. Is the pain constant? It's always there. Or is it transient? It comes and goes. Does the pain have a stable nature? In other words, nothing really makes it better or worse. Or is it provocative? We can certainly irritate it, and I can do things to make it feel better. And probably the last one that's really the most important is the pain associated with or without an impairment? The impairment meaning I have pain in my hand and I have weakness, or I have pain in my hand and I can't move it. The impairment is a much more significant scenario than just having the pain itself. So we're going to talk about how impairment and pain are important in diagnosing the problem and fixing it ultimately. Okay, so let's start getting into the complexities of the anatomy of the body, because I think it's really important to understand the way that the body works, because unfortunately the hand and wrist do not work independent of the rest of the arm. So when I look at a problem of any part of the body, I almost think of it as a system, and I start with a top-down approach. So when we consider a wrist problem down through here, and this is the back part of a person's body, we're going to start way upstream, okay? This would be the cervical spine, and the cervical spine meets what we call the thoracic spine, and it gives ribs off. So this provides a platform for which the shoulder blade and the arm actually move, the upper part of the arm. Well, if we continue down, the upper arm, the humerus, meets at the elbow, two other bones, the radius and ulna, and they continue down to meet the wrist itself. So this contiguous structure has to be relatively uniform in its movement, and it has to have good balance front and back between the musculature. When we have those things, then we have a tendency not to overuse the joints itself, the elbow, the wrist, the shoulder. Here's a picture from the front, the same thing we see, the spine, the clavicle, the ribs, and then here the arm bone, the humerus, the forearm, and into the wrist. Adding the next layer to the puzzle here, on the left we can see that nerves are superimposed on top of our bones. They exit from the neck, they pass under different structures, the clavicle, they go around different bones, and they go all the way down and extend to the fingers themselves. Here's a picture of the front part of our arm, and here's a picture of the back part of your arm. So you can see that the nerves wind and twist their way all the way down. On top of them are a lot of muscle groups, and this is not really representative of all of them because there's different layers, but I think that you can understand just from this picture that there is a ton of muscles that sit on top of nerves. So between the two of these, between the tortuous route that the nerve takes around the bone and the layering of muscles, you can see inherently that there is certain areas in the body where we can entrap these nerves, compress them, or even traction them. So as we continue to go through these layers of anatomy, you're going to be able to see the specifics behind why we get entrapment patterns and why we'll often get the symptoms that are associated with it. Here we are at the wrist, and for the sake of carpal tunnel syndrome, this is where all the magic happens, I guess you could say. This is the carpal tunnel itself. It is comprised of 8 small bones we call carpal bones, okay, that form basically a box. They're met superiorly by 2 bones, the radius and ulna, and then they are met distally by all of your fingers. On top of these bones are a series of ligaments, and as you can tell, there's a bunch of them. So these ligaments provide integrity to the wrist, and they also form the actual compartment for the carpal tunnel syndrome. By design, this area has very little room, so it makes it very likely that we're going to get compression there. Most likely why we see carpal tunnel as the most common nerve entrapment syndrome in the body. So here on the left, what we can see is we've superimposed the nerve on top of the bones of the hand and wrist, and we've included that transverse carpal ligament. That's the ligament that will compress the median nerve. So as we look down the arm, we see, and this is our thumb right here, that the median nerve passes under the transverse carpal ligament, and it provides branches. And in reality, the branches mainly go to the thumb, the index, the middle, and a small portion of the ring finger. Nothing goes to the pinky. The pinky gets its innervation from a nerve that's right next to the median nerve called the ulnar nerve, which actually goes on top of the transverse carpal ligament. It passes through a unique little canal here called the tunnel of Guillain, and then it branches and it goes down to the pinky. So by design, you can see irritation in the median nerve really only affects these 3.5 fingers, does not affect the pinky. So anytime a person has involvement of the hand that's inclusive of the pinky, they may have a carpal tunnel component to it, but they have to have something else that makes the pinky involved. So we will look at that. And here to the right, the muscular overlay, we can see that the median nerve, okay, and that's this guy here, innervates the muscles of the thumb, really innervates the muscles of those fingers that we talked about before. So one of the patterns that will happen with true carpal tunnel, because these nerves innervate the pad of the thumb, which is called the thenar eminence, it will physically get smaller. It'll atrophy. And that's clinically one of the signs that you would see with a chronic carpal tunnel syndrome. And it goes back to what I said originally about an impairment. The person may have pain, but now they also have atrophy, so they're developing an impairment. They are changing over time. This is kind of a cool angle here. This is a transection of the wrist, so you're basically looking up the carpal tunnel, and you can see the carpal bones here forming the inferior aspect of it, the lateral borders, and then again on top, that transverse carpal ligament's right there, and then here's the nerve right next to all of these tendons. So not much room in there, and if we start to overuse this compartment, then the nerve will get compressed and get irritated. It's important to know this too, because there's tendons that pass through here. These tendons can get inflamed. We can get a tendonitis, or something we call a tenosynovitis, which will cause pain in the wrist itself, which may make us think that we have carpal tunnel syndrome involving the median nerve, when in reality the nerve may be perfectly fine, because most nerves can be compressed to a pretty good extent. So the pain component may be just a tendonitis, but because of its location, we might want to refer to it as carpal tunnel syndrome. Okay, now that we have a pretty good understanding of all the anatomy that's involved, both the skeletal system, the way the nerves go, and certainly some of the muscle overlay, let's put all these pieces together and let's do an analyzation from a top down on all the things that possibly can cause hand pain. When I say all the things, there's always going to be outliers that can cause it too, but these are the most common things that are going to cause hand pain, numbness, or things that we might perceive to be carpal tunnel syndrome. And again, remember, carpal tunnel syndrome is unique to its distribution of the fingers. Always think about that thumb, the index, and the middle finger. If it involves the little finger, then we have something else going on. So let's look at each of the individual pieces starting from the top. Looking at hand pain or numbness from a top-down approach has to start with the cervical spine itself. And the cervical spine is unique in that it is a conduit for which nerves exit from the spine itself. And those nerves also exit through the thoracic spine and the lumbar spine and all the way down to the sacrum. And the location of the exit really dictates what part of the body it goes to. And you can see in this diagram here that we have shaded areas, and different parts of the cervical spine innervate or communicate with different parts of the head and the upper extremity. C3 here communicates with the nape of the neck around the trapezius area. C4 here is the upper part of the shoulder. C5, C6, C7, all the way down to C8. So, as you can see, if we start to cause irritation to these nerves, and the most common reason that we see nerve irritation is either because of some sort of bony encroachment, in other words, we get some degenerative change in the spine where the nerve exits, or for some folks, they get a disc herniation or protrusion. If we put pressure on those nerves, then what we often will find is the pain will refer away from the area involved. The person may have neck pain, maybe they don't, but they will often develop hand pain, numbness, and tingling. So if we irritate the lower cervical nerves, then all of a sudden we have a distribution that mimics carpal tunnel syndrome. And it can cause pain, numbness, tingling, and even weakness. So it really does a good job of mimicking it. So coming out of the gate, if we have hand pain, we have to start considering if the problem is upstream and if it involves the neck. It becomes a greater likelihood that it is a cervical problem if the person has pain in the neck as well as pain in the hand. As we continue down this top-down approach, we're now going to look a little bit closer to nerve entrapments within the soft tissue of the neck and extending into the shoulder. Inclusive of that would be some bony components. So as we see from this picture, there's the median nerve. You can see it exiting from out of where the neck is, and it passes between two muscles called the scalene. So that's a point of entrapment. As it continues down, it's passing real close to that's a bone right there, to the first rib. And in some people, they can actually have accessory ribs or extra ribs. They can be fully formed coming off the cervical spine, or this little area here, which is called the transverse process, can be slightly enlarged, and we might just call that a riblet. The effect is that nerve can get compressed or hung up there. As it passes down, the median nerve goes underneath the clavicle itself, so we can get irritation entrapment there, and it passes down through the arm. One of the important things that relates to all this is some of the musculature that is in the shoulder itself. There's a muscle here called the pectoralis minor that sits on top of it, and then don't forget we have big pec muscles that are all through here, and then we have the trapezius muscle up through this area. So there's lots of opportunities for the muscles to put compressive force or even traction the nerve. This type of presentation I find to be a little bit more common with people who sit or have bad posture, as opposed to the person that does a repetitive activity, like maybe he swings a hammer or it does something of that nature. So as we get contracture in the chest muscles and the head drifts forward, then we have a greater likelihood to have compression in this area. This person would most likely have some neck and shoulder pain and associated hand numbness or pain as well. So they'd have a little bit of both. Moving down, we're here into the elbow region. And there's really 4 sites of entrapment here in the elbow. This would be a front picture of it, and this would be a back picture. I included two separate nerves. We included the median nerve, as you can see right here, and then I wanted you also to see something called the ulnar nerve as well, because I mean there's more than one nerve that passes through the forearm, and again they can very much mimic each other. So the 2 classic entrapment syndromes that we talk about a lot, and again there's really 4 in the elbow. The other 2 are not as common. One is an anatomical anomaly. It's a kind of a congenital thing, so we don't see that as much, but we see these 2 somewhat. One is called pronator teres syndrome and the median nerve. So this muscle here, the pronator teres, runs right over top of the median nerve. The pronator muscle's job is to rotate the hand inward. So if I'm holding my arm straight out with my palm facing up, okay, that's called supination. As I roll my hand over so my palm is facing down, that's called pronation. And this muscle right here, the pronator, is one of the muscles that's responsive to do that. So if I'm doing this motion of pronation, and let's say that's because I'm turning a screwdriver over and over again, or I'm swinging a tennis racket, trying to put a lot of topspin on it, then we run the likelihood of starting to put compression on the median nerve. Again, that median nerve goes down to the hand and the wrist. On the flip side, if we start to put pressure on the ulnar nerve because it passes through this little tunnel here we call the cubital tunnel, then we're going to get pain into the hand itself. But like I said before, the median nerve innervates the thumb, the index, the middle, a little bit of the ring, and the ulnar nerve innervates the pinky. So again, what is your distribution of pain? Is it the whole hand or is it just several fingers? Because if it involves the pinky, then we start thinking the ulnar nerve. Quick review here, top-down approach. Again, the median nerve and the ulnar nerve, you can see them, they kind of parallel each other. The median nerve, like we talked about before, goes to the most of the palm. The ulnar nerve goes to the pinky. They have another brother called the radial nerve, and he really goes to the back side of the hand, and he goes to these fingers as well. This nerve, the radial nerve, not usually causes as many issues as these 2, but certainly can be compressed. So I wanted to include that so you see that there is a third nerve there. And as you see through here, this is the distribution of the pain pattern. So there's a ton of overlap between all of these nerves. So even though carpal tunnel is the most common compressive pattern in the hand and wrist, it's not the only reason we get irritation or compression of these nerves. It can be because of the ulnar or the radial. So again, we're always going to reference this drawing because it's important that you know that there's other causes of hand pain besides carpal tunnel. Now an illustration of when we're actually at the wrist. And again, we're going to differentiate between that carpal tunnel syndrome and that ulnar nerve syndrome. Again, is it the index finger, the ring finger, and the big finger that are involved, or is it the pinky, or is it the whole hand? Again, if it's just the thumb, index, middle, and maybe a little bit of the ring, then that truly is a carpal tunnel syndrome. Again, there's the median nerve, it's branching off and it's going to the different areas. Again, another cross-sectional view of this. Here are the carpal bones itself, so they form part of the canal. On top of the canal is that ligament. Here are the tendons that pass through the canal as well. And there is the nerve itself. So, by design, it's pretty close to everything. So it doesn't take much to cause irritation or compression. Here, again, another really good illustration of the ulnar nerve as it passes through its own little unique tunnel called the tunnel guion, and it goes to the pinky. So we can have tunnel syndromes that involve the ulnar nerve, and we can have tunnel syndromes that involve the median nerve, or we can have both together. Again, because these nerves innervate the hand, they have unique distributions, and we always want to keep that into account when we're considering what the problem may be. The next question would be, are there other scenarios that cause hand pain outside of having a nerve entrapment? And the answer, of course, is yes. So let's talk about some of those. The first thing that we see is we can have hand pain or numbness that's referred from areas very far and distal from the hand itself. In this picture that we see here, this is adapted from a book from an author named Janet Travell, who was just a brilliant doctor who mapped out all of the trigger points in the body. A trigger point is an irritable portion of a muscle that usually has a tight band in it, maybe an adhesion. And the characteristic part of that trigger point is when you push on it or irritate it, it radiates pain away from its location. So if you see here, these are those scaling muscles that I talked about before. Remember, the median nerve passes between them and they're a point of entrapment. Well, what if these scaling muscles are irritated, not enough to contract the median nerve, but enough to develop trigger points like these little X's? Then we will often see a distribution of pain associated with it. Here in the hand, we can see it's in the distribution of what we would think would be carpal tunnel syndrome, when in reality, it actually isn't. We can also get referral to the back of the arm, the back of the shoulder blade, and these little dots as well. So there's a huge referral area for trigger points. The important part about these trigger points is they're reproducible. In other words, when you press on them, they can be diagnostic of the problem. If I push on that muscle and I feel it in my hand, that's giving me a pretty good indication that there's a trigger point there. And the good thing is, not only is that compression diagnostic, it's therapeutic. So you would basically treat it the same way by doing different soft tissue techniques that we'll talk about later, different stretching and stretching protocols. So we always want to think about referred muscle pain. How about pain referred from a joint and ligament? This is called sclerotogenous pain. The nerves of our joints are highly vested for sensation, meaning that our joints tell our brain and the rest of our body if they're happy or not. If there's inflammation, if there's irritation, if there's compression, if there's shearing, it tells it all these things. So if we start to irritate these joints, maybe because we have arthritis, or maybe because there's a fixation and the joint just doesn't move well, or maybe there's just thickening of the ligaments that surround the joint, then we can get a referral of pain from that as well. And in this illustration here, we can see that ligament irritation or joint irritation in the upper cervical spine will refer mainly to the neck area, to maybe even to the chin, the middle cervical spine to the shoulder area. But as we get down here to the lower cervical spine, we can see it refers to the hand as well. So for a person who has just old-fashioned arthritis in the neck, maybe some thickening of the ligaments, because that's what happens when the joints break down over time, then that in itself can refer pain into the hand, which would make it similar to a carpal tunnel, when in fact, again, it isn't carpal tunnel. Now, the elephant in the room many times is something that we call double crush syndrome, which means that we're getting compression of the nerve in at least two spots and sometimes maybe more. I see this pattern in increased frequency over the last, 15 or 20 years, because people's posture seems to be getting worse as time goes by. Remember, we talked about the top-down approach. So if a person has degenerative changes in their neck, we start to irritate the nerve there. So as we move down and the shoulders start to slump forward And the neck is held forward because we're always at a desk. We start to put more traction on the nerve there. We use a mouse all day, and when we hold a mouse in the hand like I'm doing right now, I'm in that pronated position, palm down, which means that that muscle is being activated, so the nerve can be irritated there. Of course, it can be irritated in the carpal tunnel because that's really a lot of this presentation. And the end product is we get hand pain, be it classically in the thumb and the other 2 digits or in the pinky or in all of it. The take-home message here is we can have compression in 2 sites. This scenario is extremely likely with the person who said, hey doc, I've had hand pain for a long time. I got surgery. The hand pain, it did get better, but I still had this going on. So whatever was still left and whatever was still going on is most likely another crush syndrome somewhere upstream. So ideally, if you work your way from the top down, you can identify all those areas of entrapment and you can deal with them individually. It's like pulling layers away from the scenario, but if you do that, the outcome is almost always better. In medicine, taking a history is probably the most powerful portion of the patient encounter because it gives you really 80% of the diagnosis. If you don't ask the questions, you're not going to get the answers that you're looking for. But you're going to want to build onto your diagnosis by doing other things, examinations and things of that nature. And you really want to differentiate carpal tunnel from other types of causes. Again, it's going to be pain and numbness in the thumb, the pointer finger, the middle finger, maybe a little bit of the ring finger, never in the pinky. We're going to possibly get weakness in the muscles of the thumb. We maybe get atrophy in that area of the thumb. That fullness is called the thenar pad. We'll get positive orthopedic signs. If I tap over the carpal tunnel, it may cause me to have more numbness or more pain. If I bring my wrist into flexion, I bend it down and I make that tunnel smaller, or I extend it back and I stretch the nerves out, that certainly may cause some problems as well. In many cases, if we really want to be sure about the condition, we would do what's called a nerve conduction study, meaning that we would check the ability for that nerve to conduct an impulse from one place to the other. If there's a latency or if it's decreased, that really tells us that the nerve is irritated there. In many situations, we would want to take an x-ray. We want to rule things out. Is there arthritis in the wrist? Is there arthritis in the elbow or the neck? Remember, you can compress upstream. And we may, in some people, want to rule out an underlying autoimmune or inflammatory type scenario. When I first started, we talked about know your pain type. So if the person has a tendency to more of a global scenario, yes, their hand bothers them a lot, but they get other global pains. I get my knee hurts, or I get shoulder swelling on the opposite side. Then tests to rule out inflammation and autoimmune become a really good tool as well. Additionally, we have some other metabolic mimics of carpal tunnel syndrome or hand syndrome, something called Raynaud's phenomenon. That really more involves coldness in the hand, but it can involve pain. Hypothyroid, this is one that can mimic joint problems. When we have a hypothyroid situation, we have a greater likelihood of having edema in the body or swelling, because the carpal tunnel is a relatively small compartment. Any kind of extraneous swelling of the soft tissue may cause compression of the nerve and mimic a carpal tunnel syndrome. How about gout? Yep, gout. Gout is classically thought of when it comes to the big toe, but gout can affect other joints, the wrist being one of them. Not super common, but it has to be in your differential diagnosis. Again, I touched on before, autoimmune disorders like psoriatic arthritis will cause it. Changes in hormone balance, especially for the ladies when we have an estrogen dominance. Again, it goes back to similar to the thyroid. We have a tendency to be edematous. We hold more fluid, which causes compression. There is a unique valve in the digestive tract called the ileocecal valve that you don't hear talked about very much in the medical community, and it really probably should be. The ileocecal valve is a valve that opens and closes between the small intestine and the large intestine, and it's really important to compartmentalize those contents. So when that valve becomes slightly incompetent, and it typically happens maybe because our diet is poor or we eat a lot of inflammatory foods, if we start refluxing contents of the intestine backwards, then the body's going to try to compensate by diluting that toxic material, and it's going to hold water. Again, holding water throughout the body will cause tissues to swell, and it may mimic a carpal tunnel. Some folks have forms of neuropathy. The classic one we all know about is diabetic. Well, there's other reasons that nerves can be irritated. And a neuropathy, a peripheral neuropathy, may cause hand pain, which very often might be misdiagnosed as carpal tunnel. Some folks who've had previous infections, be Lyme or Lyme co-infections, can get transient neurogenic patterns or nerve type patterns. And some folks who've had cortisone therapy in the area of involvement, okay, they get injections in the wrist, may develop damage to the nerve or the soft tissue right there, because you have to be pretty darn good when you do the injection that you don't get too close to sensitive tendons or the median nerve itself. So these are all what we call metabolic mimics of carpal tunnel syndrome. All right, so let's put all of this together and come up with a good flow chart for a diagnosis, okay? And this is how we clinically assess any kind of complaint. The first thing is something called part. We palpate it. That's the P. That's probably one of the most important parts, and to be honest with you, that's probably being dropped out in physical medicine faster than anything else. Most doctors just want to see an X-ray and MRI. They don't even want to touch the area of complaint. That's problem number one. The second letter is in A, is that we look for, is there asymmetry? Is it different from one side than the other? The range of motion, that's the R. And the T, the texture, the tone. Does it feel warmer? Does it feel colder? So we actually got to physically look at the area involved, and we need to actually contact it. We're going to do orthopedic and neurological testing at this point to confirm what our thought process is. Remember, I said if you take a good history, that's probably going to give you 80% of the diagnosis. Well, your orthopedic and neurological testing are going to help you refine it. Okay, you're going to start with a big basket of probables, and then you're going to bring it down to less and less. In some cases, you might want to look at a person's posture and gait. We talked about the double crush. So double crush is extremely common with people who have very forward projecting shoulders and anterior head carriage. We call that something called upper cross syndrome. So if the posture is poor and maybe the gait's poor, they don't walk normally, then they're going to shift their body. They're going to become different to acclimate to it. So we want to look at that. In my profession, in chiropractic, it's essential to make sure that the spine itself has normal mobility and that we're not compressing or irritating a nerve. We call that a subluxation. If we're putting irritation, either compression or traction on a nerve, or we're irritating a joint in the neck or the middle back or the low back, or the joint has lack of mobility, and we refer to that as fixation, you're coming out of the gate one step behind. So you have to assess normal joint motion in the spine, because that's the foundation of the body. And because it's so far upstream in the neurological system, if we start to irritate it there, then everything from that point on is going to be compromised. Muscles move bones, and we want to look at the way those muscles interact and move, and there's a specialty called applied kinesiology. If we have muscle weakness, we need to figure out, why is that muscle weak? Is it weak from conditioning? Is it weak from neurological influence? Is it weak because there is a nutritional component? You sequentially want to look at all of those. In some folks, their inflammation and chronic pain is being perpetuated from a really poor diet. These are the folks that are chronically inflamed. Their diet is nothing more than white foods, white flour, sugar, pasta, breads. Very often they love their foods that have preservatives and additives and stabilizers. These are all what we call neurotoxins, and they're extremely inflammatory in nature. If a tissue is already inflamed and you add inflammatory foods to the body, you're going to just throw gasoline on the fire. On top of that, if you don't give the body the nutrients to heal, then we have a chronic inflammatory state that just festers over long periods of time. It becomes nearly impossible for the body to repair itself if it's just inflamed all the time. It's like trying to rebuild your house while it's still on fire. Probably not a good idea. We often will look at diagnostic imaging as a confirmation to what we think that we're dealing with. In other words, we run through these steps. I'm pretty sure this is what I have. Let's confirm that it isn't something that we've missed. So that's when we're going to get an X-ray, an MRI, a CT scan. That's a special type of X-ray. We can add on top of that, let's rule out that we don't have an autoimmune or chronic inflammation. So we might want to do laboratory testing or functional testing, maybe even possibly looking at hormones. So now that Mr. and Mrs. Jones had their full workup at their doc and have been diagnosed with carpal tunnel syndrome, and let's hope that's what the diagnosis is, what will we conventionally see done for the problem? Well, anti-inflammatories are certainly something that are put into place. The issue becomes with the anti-inflammatories, if we take them over long periods of time, there's side effects, gastrointestinal bleeding, possible liver damage. And the real elephant in the room with this one is for folks that take Advil or anti-inflammatories, what we call NSAIDs, for long periods of time, we clinically know that it sabotages the body's ability to utilize sulfur. And sulfur is really the building block of a lot of our connective tissue, specifically cartilage. So long-term anti-inflammatory use leads to progressive cartilage loss on its own. And I'm not talking we're getting cartilage loss because we are physically damaging it. It's because you're sabotaging it by taking the anti-inflammatories. The next classic one that I would see would be a muscle relaxer. Okay, the problem, many times I just don't see people getting any benefit from that. They just tell me, it didn't seem to do anything. But they come with side effects as well. You can get to people become dependent on them, and certainly can make them tired and impair their cognition. And then the next two are really the slippery slope that fortunately we're seeing a move away from, that usually were pretty common. The first thing would be bracing the area. Now, bracing something that is extremely inflamed or hot, that we might call it, or certainly broken, is good early on, but we don't want to fall back on using bracing as our go-to all the time. In other words, Miss Jones types a lot for her job, so she gets what's called a cock-up splint for her wrist, and that's something that holds her wrist up, and that's used a lot with carpal tunnel. So she just decides to use it all the time because it makes her feel better. She doesn't want to address the problem. She just wants to kind of keep it the way it is. The issue with that is the muscles that should stabilize the wrist now, because they've been taken out of their primary role, develop weakness. And if they weaken enough, then we develop an impairment. Remember I talked about impairment? That means that we can quantify this objectively, that the person has started to change over time. So bracing is okay on the short term, becomes a bad idea on the long term, especially when you haven't tried any type of rehabilitative or corrective things for the problem. And the last one, and we don't really see this that much, but it used to be, definitely a prescription, was just bed rest. Tell people just to, don't do anything. Okay. Again, it goes back to the muscle atrophy. And for some folks, they get neurological regression. If you stop doing a task or an activity, then your brain kind of forgets how to do it. So this is what we see classically done. Let's look at things that we probably should do instead of this if you really want to address the underlying issue. So how would you work with the musculoskeletal system? And notice I put together muscular and skeletal. I probably should have thrown in neuromusculoskeletal system, because you can't, again, compartmentalize just treating the nerve or the muscle, the skeleton. They're all inherently tied in together, so you're going to want to address them together. So from a standpoint of what we do in our office, the first thing that I look at is, does the spine and the other joints of the body have normal mobility, and or are they irritating any nerves that are local to them? So if we're having reduced motion at a joint, be it at the spine or at the elbow or the wrist, that has to be restored. Okay, the health of a muscle is directly proportional to how healthy the joint that it crosses. So in other words, if my elbow joint is really arthritic and I can't straighten it all the way out, and maybe I can't bend it all the way up, then the bicep, that's a muscle that crosses it, and the tricep are going to be caught up in this, and they're not going to be as healthy. They're not going to be able to elongate and shorten like they should. So their function is going to change. So we might want to address the bony component and make sure that it moves, that subluxation. And if the muscles are starting to get shortened and tightened because the joint is dysfunctional, then we might want to get in there and actually do some releasing to the muscles themselves, soft tissue work, if you will. Many people have habitual tightness and have weakness in muscles, so we don't want to forget that stretching and strengthening becomes an important part of a treatment plan. Again, I look at strengthening and stretching as an adjunct to addressing the bony component, because there's a hierarchy. If the joint is dysfunctional, then the muscle is going to be dysfunctional. So you always want to start with getting good function of the joint, and then address your muscle function, looking at strength and length. Correct ergonomics. People just have very poor posture, be it at work or at home. The invention of the cell phone is going to be the downfall of kids, because their heads are so far forward and they're always looking down. So I'm sure in 20 years from now, we're going to have a huge spike of osteoarthritis in necks, and we're going to have a huge uptick in tension headaches, just all because posture and ergonomics have become poor over time. There's therapeutic modalities that have a lot of value in reducing inflammation, minimizing pain and muscle spasm, and increasing blood flow. If you do those three things, that's like putting the fire out in the house. You get rid of the inflammation, you get rid of the person's pain and muscle spasm, and you increase the blood flow, then you can rebuild the house. So I really like to use things like cold laser and ultrasound, because they stimulate this process, and you always have to be thinking about controlling inflammation and increasing blood flow. That's the way the body heals. In certain situations, we might want to consider adding in some nutraceuticals, some vitamins or minerals. B6 is classically used. Upwards of between 100 to 300 milligrams a day of B6. I like something called B6 phosphate. That's a phosphorylated version of B6, so its bioavailability is much better than some of the other forms that you would see commercially made, especially in inexpensive vitamins. I like proteolytic enzymes as my anti-inflammatory, as opposed to Advil or Tylenol. Proteolytic enzymes are enzymes. We've heard of bromelain and papain. Those are the two classic ones that are designed to help break down proteins, which inflammation is, and we take those on an empty stomach. If we want to add in more systemic anti-inflammatories, that would be great too. We could add in omega-3 oils, turmeric, curcumin, those types of things. Those are great as well, and they have more of a little systemic quality to them, which is fantastic, because most people who have inflammation have it globally. They might not know it. And again, we want to review our ergonomics. If we don't correct the underlying scenario that causes us to have the carpal tunnel or the cubital tunnel or any of these other syndromes, then we can get the therapy and the rehabilitation. A person can come to my office and get treated, but if they don't make changes at home, when I stop treating them, then they're probably going to come back and 2 or 3 months later complaining of the same thing. Well, what about just being well? Well, I break that into what I call the 4 R's. And these are just things that I talk to my patients about in general. So when a person becomes stable and they're healthy, well, what can we do to maintain this? The first thing that we would do would be remove things. Subluxations, that's that bony impingement of a nerve. We change the diet. We change habits that might contribute to us. We would start to replace things, the macro and the micronutrients. Make sure that diet is good. If you're not eating well, your outcome is not going to be as good, and you're not going to recover as quick, and you're probably going to have more other problems going on in the background. Hydration becomes a big one. A lot of folks don't like to drink water, and connective tissue is probably 65 to 70% water. So if you don't drink it, you're gonna lose it in your connective tissues, which is going to make them fail prematurely. And I put mindset in here because some people think that once they're in pain, they're always in pain. So you have to replace that mindset. That's not going to be the case. And you need to look at rehabilitation. That would be the 3rd R. So you want to rehabilitate the muscles, the joints, the form, okay? And that's the way you move and your gait. And then ultimately the last R is you want to review your health and athletic goals. So if a person comes in with carpal tunnel syndrome, or what they think is carpal tunnel syndrome, and they're a big golfer, their goal may be, I want to go play golf. Well, that's a great goal. That's a kind of a long-term goal, but we should also have short-term goals, and their short-term goals should be they should be able to do activities of daily living. They should be able to do things around the house and not have pain. So we want to develop short-term goals and eventually those long-term goals to get them back onto the golf course. So in closing, we went over a lot of different concepts, and unfortunately, because we're doing this as a webinar, I can't answer any questions in person. So I encourage you, if you have any questions, to contact me at the office. You can email me. I'm not sure if we can add in questions to the website itself. I'll talk to the people about maybe adding in that function. But what I am going to do is for those folks that have concerns that they really need to get addressed, we work with an organization called Caring for Others. It's an organization in Northern Virginia that helps the homeless and needy. I donate time. The other doctors donate time to them several times a year. I'm going to allow folks to come into the office if they've never been, or if somebody hasn't been in over a year. They can get a full workup. I can go through all these concepts that we talked about, and we can come up with a plan to fix them. Normally, an exam in our office is $225. We're going to do it as a $99 donation directly to CFO. So if you're interested in that, please feel free to call the office, and you can talk to Sybil or one of the other ladies, and they can get you in to see me. If you have previous medical records and all that type of stuff that pertains to your complaint, then by all means bring that. And again, I encourage you, if you have any questions, just to reach out. And I look forward to seeing you all in person here in the near future.